Hello, everyone. Welcome to our December ICARE Case Conference. I'm Tua Pal, and I'll just walk you through a few housekeeping details, after which we will get started on our guest expert presentation. So in terms of the schedule for next year, just wanted to highlight that our case conference will remain every second Thursday of the month unless there's a conflict, but we are moving up the time by 30 minutes. So it'll be 11 to 12 Central Time or 12 to 1 Eastern Time. These are the scheduled sessions for next year. So we have a really exciting lineup with guest experts from across different disease sites and different disciplines. So again, we're really excited about what we have lined up already. Again, just a brief reminder. We thank everyone for continuing to refer to our registry. We've tried to make it as easy as possible. We have the online referral form directly from our website, as well as printed postcards, if that is something you're interested in. The other thing is we also encourage you to submit cases to our case conference. We like to make these collaborative and interdisciplinary. So again, we've tried to make it as easy as possible. There's a REDCap link through which you can submit your cases. And they really don't need to be aligned with the theme of the case conference. Here are some resources that we have available. We're all attending right now the ICARE Case Conference. We do biannual newsletters in the spring and fall with updates. We have a website that's got a lot of searchable resources, and then we are active on social media on your platform of choice. So if that is something you're interested in, please follow us. And then these are just examples of our social media posts, which include talks, newsletters, open studies, educational stories, research updates, as well as guideline updates. And then just an eye care focused effort alongside my colleague Sonia Reed, we're continuing to recruit for our study focused on characterizing hereditary breast cancers through both tumor testing, both on DNA sequencing as well as RNA-seq. So we thank all of our partners for continuing to refer to our registry. And then last thing I just wanted to mention, there is this monthly journal roundup that is really led by the UK group. And they put together these summaries of recent publications focused on cancer genetics. If that is of interest to you, please email the contact directly. On top of that, if you want to contribute, my understanding is you can also contribute new articles that may be from yourself or others that you'd like highlighted in this. So again, please contact just Kieran Gill directly if that is of interest. So with that, it is my great pleasure to introduce our guest expert for today, Dr. Ben Park, who is also our Cancer Center Director at the Vanderbilt-Ingram Cancer Center. He's an internationally renowned breast cancer expert and a pioneer in developing approaches for studying circulating plasma tumor DNA and the use of liquid biopsies for cancer treatment. He was the first to identify the high frequency of PIK3CA mutations in breast cancer and discovered their contributions towards oncogenic phenotypes. And he's also made some fundamental contributions to the field of drug resistance, including hormone therapy. So with that, I will hand it over to Dr. Park.
First of all, thank you, Dr. Powell. Thank you, everyone on the ICARE team for inviting me. This is really an honor. And I'm going to talk today a little bit about some new work that has taken, I guess it's new and old. It's been about a decade since we started some of these studies, but hopefully I'll be able to walk you through how we got involved with this journey, really from the very beginnings of what we now know today as liquid biopsies and circulating tumor DNA. And I love puns, as Tua knows. So the breast is yet to come is something I keep saying over and over again, because I think it's really applicable when it comes to ctDNA for breast cancer therapies. These are just some of my disclosures. I think many on this audience probably already know that the goals of what I do as a medical oncologist is to give systemic therapies like chemotherapy, endocrine therapies, biologic therapies, and immunotherapies nowadays for breast cancer patients. But really, in a large kind of 10,000-foot view, I like to think about two real goals of therapy for patients when I see them for the first time. One is in metastatic patients. We largely cannot cure metastatic disease in breast cancer. We're getting better at some subtypes like HER2 positive, but it's really about prolonging life and treating the symptoms and really getting as much quality of life as we can while we're treating actively the cancer. On the other hand, the majority of what we do in breast medical oncology is in the adjuvant setting. This is for early stage breast cancers where we know there's going to be a certain percentage, sometimes very high percentage, up to 30% of patients who are going to come back with incurable metastatic disease. And so despite screening with CAT scans, PET scans, et cetera, you can't see it. It's microscopic disease. And we know these odds from historical controls, randomized controlled trials that really show placebo groups actually have about X% recurrence rate, depending on, the type of breast cancer and the stage. So what we're trying to do is when we flood the body with chemo and other therapies, eliminate micrometastatic disease. And we know that this works from those so-called trials, which are in the next slide, that if you take a group of, let's say, 100 patients and you get surgery and nothing or placebo afterwards versus another well-matched group for age, stage, and type of breast cancer and give those patients chemotherapy, the group that gets chemotherapy as a group does significantly better. This is about 13 percentage points, but in the United States, that translates into tens of thousands additional lives annually that are cured because of additional adjuvant systemic therapy. Putting into context in the old thing that we called adjuvant online, if you were to do only surgery at 10 years, the green bar would be how many patients would be alive. Again, this is just one example. And then in the red bar, about a third are going to die from their breast cancer, and another 4 or 5% are going to die from other causes. The absolute benefit of chemotherapy in this example is here in the yellow, again, about 13%. So we're not curing all patients that are going to have micrometastatic disease, but we make a big enough impact that we know the risks or the potential toxicities or risk of toxicities are not outweighed by the benefit. There is a toxicity, though. If you look at death by other causes, it's a little bit bigger. And we know that chemotherapy can rarely, in other therapies, actually lead to long-term morbidity and even mortality. The problem with this approach, however, is that one, it takes forever to do these types of trials because your only readout is, hey, how many patients at 5 or 10 years have recurred versus the control arm. And also, it leads to the paradigm that we are currently in, which is we overtreat and even undertreat patients every single day. What do I mean by that? Again, taking this bar as an example, if you actually see that the patients in green here, it says receive chemotherapy needlessly. We don't know on an individual level whether that patient is in the 60-70% of cured patients after surgery. So we treat everyone if they have the right indications for it. We also don't know who are the ones that get cured from chemotherapy, and importantly, who are the ones that are not. And so that's been kind of the unmet need and biggest conundrum for decades. And that's how we first got into this business and started thinking about, hey, if we had a tool, a diagnostic tool that could really reliably measure microscopic tumor burden, that could be a great game changer for this conundrum and unmet need. So we started thinking about blood tests, and I'm going to next slide of what liquid biopsies and ctDNA really are. But the concept is very simple. If a patient has breast cancer, denoted here, and the black spot in the breast is a breast cancer, that patient should be positive for this blood test. And then after surgery, if that patient is cured, they'll be in the 63.1% in this example, shouldn't need any further therapy. On the other hand, if that patient is positive by the blood test, then we know that patient still has microscopic disease and we can start our adjuvant therapies and importantly, monitor it during the adjuvant therapies. We don't do that now because we have no metric or readout. And so what this allows us to do is then follow patients and make sure that, in fact, the adjuvant therapy is working or not working. Again, that's the hypothesis, that's the theory, and that's what we really set out to do a number of years ago. So what are we actually looking at? Circulating cell-free DNA or cfDNA is really not a new thing. We've known about cell-free DNA for decades, and we just didn't have tools to really analyze this. And so all of our cells shed naked, free-floating DNA into the circulation. We don't think that this has a purpose or a function. I've been known to call it cellular poop because many people like me think it's a waste product. But if you think about all normal cells shedding that into the circulation, then cancer cells also do the same thing. Remember, though, cancer is a disease of DNA gone awry. The mutations, fusions, and all this other stuff is what drives a normal cell to become a cancer cell. At the same time, that's the Achilles heel, both from a therapeutic standpoint, meaning that we now have drugs that can target certain DNA mutations or their protein products, I should say, as well as from a diagnostic standpoint, because all these cancer cells are also shedding little bits of DNA, their DNA into the bloodstream. And that's what we are focusing on when we call circulating tumor DNA. It's just cell-free DNA from tumor cells. This is a really good analyte as a biomarker because the half-life is very, very short in the plasma. And unlike what this diagram is showing, it's really the case, even in metastatic disease of heavy burden, that most patients will have a relatively small fraction of ctDNA compared to the total cfDNA. Sometimes we're talking about 0.1%, 0.01%. And so the tools started really coming into existence about 12, 15 years ago. And we first started with something called digital PCR. I love showing this because it's a great example, as long as you're above a certain age group now that knows what Where's Waldo is. But if you imagine that this whole picture is a drop of blood and that every person represents a piece of DNA or some sort of locus, we're only going to be interested in the pieces of DNA or the locus of individuals wearing horizontal red and white t-shirts or shirts, and that Waldo is the mutant allele, if you will. And so what digital PCR does, and this is really the predecessor for next-gen sequencing, is isolate single DNA molecules and amplify them. And you do this rapidly in parallel, and then you can actually quickly and easily find the mutation, in this case, Waldo. We did a proof of principle study. This was published, I think, in 2013, 2014, so quite a while ago, over 10 years ago. This is when I was at Johns Hopkins, and it was simply early stage breast cancer. And I think it was really the first early stage breast cancer pilot study that was done using circulating tumor DNA, again, to see if we could pick up microscopic residual disease. I'm not going to belabor what the study is in the interest of time, but one of the things that we got out of this was this last table. And I'm just pointing the ones in the red because these are patients, we were looking just for a certain mutation of PIK3CA, and these are patients who had persistent PIK3CA mutations in their blood after surgery. Now, some of them got adjuvant therapy, some of them didn't, but you can see for patient number 16, that one was actually predicted or actually preceded clinical recurrence. And unfortunately, the patient ended up dying by a couple of years. On the other hand, if you look at patient 5, that patient had a mutation pre-surgery, but not post, and had a long-term follow-up with no recurrence. Some of our patients on this study actually did get scanned, number 16 being the example, and did not have overt metastatic disease. In breast cancer, we don't scan routinely anymore. And so one could make the argument, well, you don't really know if you were finding microscopic metastatic disease, but in fact, for that patient and a couple others, we were. So with that in hand, I'm going to skip the summary. We decided that we were going to do the big study, and we were going to do it in neoadjuvant patients. So why neoadjuvant therapy? Well, it turns out in stage 2 and 3 breast cancers that are HER2 positive and also triple negative, meaning that they don't have estrogen, progesterone, or HER2 receptors, if patients get chemotherapy up front and then go to surgery, and there's no tumor at the time of surgery, that's what we call a pathologic complete response, or PCR. And that's a very favorable marker. In fact, the FDA has approved its use as a surrogate endpoint to try to get drugs provisionally approved faster. There's a couple examples like pembrolizumab, pertuzumab. We also know now that if patients have residual disease, meaning they don't get a path CR after the upfront chemotherapy, that those patients don't do as well. And now we even have additional drugs that we give those patients. I always want to couch a couple of caveats when I meet a patient for the first time, because patients get really fixated on pathologic complete response. And I always impress upon them, even if you don't get a pathologic complete response, you can still be curable. The odds may not be as high, but it is not like everyone's going to die if they don't get pathologic complete response. All right. So this was the study, and the provocative part for me was, hey, if we could actually prove that if you clear your ctDNA after chemotherapy, does that predict for pathologic complete response with an acceptably low false negative rate? Because if it did, in the future, we could offer patients a no surgical option. My surgical colleagues, when I pitched this 10 years ago, weren't too thrilled about that, but I think they eventually understood when I said this is kind of like the sentinel lymph node biopsy and precluding axillary lymph node dissection. So that was the paradigm. And then, of course, we could continue to follow them to see whether or not patients would be really associated with plus ctDNA being disease is going to come back, or minus ctDNA meaning they're negative. Does that actually mean patients are cured? That to me was always the most impactful endpoint. We threw in the prediction of path-CR because I wanted to throw some clinical utility behind this study. So this was the study. I was very proud of this acronym. It took me hours to do. This was well before the days of AI and ChatGPT, because it uses the first letter almost of every single word to form predict DNA. This was done through the Johns Hopkins Clinical Research Network, as well as the Translational Breast Cancer Research Consortium. It's very simple: stage 2 and 3 breast cancers, HER2 positive, triple negative. And we collected tissue and blood all along the ways to, again, see if we could predict for path-CR reliably, as well as can we actually associate presence or absence of ctDNA at this time point with long-term survival, disease-free survival, or recurrence. So I was really disheartened earlier this year, actually end of last year, when in fact we did not meet our primary objective. And even though every patient who had a path-CR was ctDNA negative after their chemo, our false negative was unacceptably high, meaning that there were 40-some patients who did not have path-CR, you can see that here, but were ctDNA negative. So that was really disappointing, except when we looked at those patients. So this is the traditional plots you may see when you look and stratify patients by path-CR versus not. And this is only in the triple negative breast cancer. That's where our pre-specified endpoint was, because these are patients that recur much more readily than HER2. And we actually use the strictest definition. So this curve probably in most cases would be lower, but we included patients with in situ disease, which are typically considered path-CR from a clinical standpoint. The reason behind that is that in the future, again, we wanted to offer patients a no surgical option, and you can't leave in situ disease behind. Now, when we looked at ctDNA plus or minus, I should just say this was just, we had some culling because not everyone that we had path-CR data on actually had all the ctDNA. So we wanted to make sure that our ctDNA group represented the overall group, and they did, as you can see. This was the most exciting part about this for me, was if you look at just ctDNA status, this is again after chemo, but before surgery, you get this huge separation of these curves. And as I already mentioned, this includes patients who are ctDNA negative, but non-path-CR. So what we have found is an actual independent prognostic indicator for neoadjuvant therapy in triple negative and even HER2 replicated this, that is actually better than pathologic complete response, because it really does separate out those curves much more appropriately. But also you can see, even if you don't get path-CR, you can still have an outcome just as good as PCR if your ctDNA is negative. These were presented by ASCO, by the way, in this past June in our big meeting. We have another paper. I can't show you the data yet, but it's even more compelling. But essentially, this is looking at post-surgery. And essentially, the post-surgical is really dichotomized, that if you are positive, everyone relapses within 3 years. If you're negative, almost everyone does really, really well. Our longer-term follow-up on the 5-year, probably, I think it's upward of like 94% of patients, if they're ctDNA negative post-operatively at 5 years, still don't have any recurrence. And again, everyone who's positive post-surgical will actually recur within the first 3 years. All right, so the conundrum. I forgot to mention the test in the interest of time. We're using Personalis. I think they are commercially available now. They weren't, but we had early access. So we've been offering this here at Vanderbilt-Ingram Cancer Center for probably about a year now at this point, but I think they're now widely available. And it's an ultra-sensitive test. They're using 200 to 1,800 mutations per patient to track the ctDNA, and that's what really helps the sensitivity. It's about 1 in a million. All right, so the conundrum that I'm facing now is that patients know about these tests. They want these tests. There's several different iterations from other companies. Signatera now has a Gen 2 test that they also claim has a 1 part per million sensitivity. Their old one was 100 parts per million. But we still don't know for sure whether this is going to help us help patients. False negatives still exist, and I'm sure always will. And this applies for some of our data as well. The specificity and positive predictive value, though, are super, super high, again, because we're looking at 200 to 1,800 mutations. And so can acting on this lead to improved outcomes? That's the real question right now. We're living in a data-free zone, and people are getting these tests. So what is one to do? So as I mentioned, false negatives are still present. What do you do with a positive result? I always try to have a plan. Is there a clinical trial? Is there additional adjuvant therapy that the patient hasn't seen yet? I always make sure that we scan a patient if they're positive because they have overt metastatic disease, then the goals of therapy shift. We also have to make sure that we eliminate and reduce financial toxicities. This test was just approved by Medicare about 3 weeks ago. And then I also explained the limitations of these types of assays. I had a patient who had a first-gen test of Signatera come to me, and she wanted this test, but she didn't have enough tumor anymore. So I warned patients, you know what? If there's a Gen 3 test 3 years down the line, we may exhaust the tissue using this test right now. And you have to, I think, counsel patients about that. I also counsel everyone about not underestimating anxiety from these tests because they can lead to anxiety that is far, far higher than any X-ray, CAT scan. So people need to really think about this. And I've actually had 4 patients decide that they don't want to do it after I've counseled them about this. And then always have a plan. If it's negative, we need to repeat it, usually every 3 to 6 months. If it's positive, again, staging scans. If they're negative, what are you going to do with the therapies? Total data-free zone. This probably needs to be updated. I've ordered way more than 20 tests at this point. And as I told you, it's 4 patients that have declined after discussions. I have some of these vignettes. And again, I'm happy to share these slides as was mentioned. But this last one is compelling. A patient of mine is a young woman with 2 young kids, and she had triple positive disease. And she had 3 parts per million on her tests. And so we scanned her up and down, and I didn't think we were going to find anything overtly metastatic, and we didn't. But she could get a different adjuvant therapy. She had already done a year of TDM1. And so we got her neratinib, which is also approved for HER2 positive disease. We don't use it much because it doesn't have much bang for the buck in terms of the number of additional patients, but it also has toxicity, especially diarrhea. But we repeated that test after 6 months, and this was the result. So she has now cleared her ctDNA, and she's not out of the woods yet. We're going to give her the rest of the 6 months, and early next year, we'll take it again. But I really think we have given this patient a second chance of cure by finding the ctDNA early on and then giving her some additional therapy. So people, this is kind of like religion. You either believe it or you don't at this point until we can prove it. But I always say perfect is the enemy of good enough, stolen from Voltaire, who said perfect is the enemy of the good. A lot of my colleagues will say, are we opening up Pandora's box? And I think we probably are. But the horse is out of the barn already. Again, patients are getting these, whether we like them or not. And I feel like our job is to actually help adjudicate these results and actually help both providers and patients figure out what is the best course of action. And I also point out that at the end of the story of Pandora's box, hope is the last thing in there. And that's really my hope, is that, again, the breast is yet to come. I think these are going to be game changing. We have to do the trials to prove that. But until then, because those trials are going to take another decade, I think we can help a lot of patients. And that's my own personal opinion and view on that, which is, again, not shared by everyone. Just want to thank everyone from the lab, all the past collaborators, funders, and especially our patients. And with that, I'm happy to take questions.
Thank you, Ben, as always. That was great. There were already some questions in the chat. One question was, how was ctDNA detected?
Yeah, I saw that one. So that's, again, it's a Personalis is the vendor that we're using, the company. And what we do, this is tumor informed. So every patient from their tumor biopsy or their surgical sample gets its sequence. And they use what we call whole genome sequencing so they can find a lot more mutations. Then they will actually find anywhere from 200 to 1,800 mutations for each patient, design probes to look for the ctDNA in the blood. We take the blood, we spin it, we get plasma out, we extract cell-free DNA from that plasma, and then within that gamish of cell-free DNA, we're looking for the ctDNA molecules. Those 200 to 1,800 probes are the ones that are looking for them.
Okay. And can you comment on the different platforms? Do you want to, because you're probably better qualified than anyone to kind of talk about
Yeah,
what are the different strategies just in a nutshell, because we know that there's a lot of commercial offerings out there.
and there's different uses. So most of the commercial offerings right now are not that sensitive. They get down to about like zero point 0.1 to zero point zero 0.01. Those are really for patients with metastatic disease where you could detect mutations that you're looking for that are druggable. And that's very different than this. Most of the times for these types of assays, there's tumor informed, which is Signatera, as well as Personalis and a few others, Haystack Oncology. And there's tumor uninformed, which are things that you don't need to use the tissue. There are advantages and disadvantages. Right now, the tumor uninformed are the same tests that people are trying to figure out, can we use this for primary screening for, let's say, BRCA1 and 2 patient or carriers that we want to know if they're getting cancer of any type. That makes more sense because you don't have a tumor yet. And you're looking for different things like not only mutations, but what we call epigenetic changes in the DNA, methylation, histone acetylation, et cetera. They're not going to be right now as sensitive and specific. On the flip side is these tumor informed, because they are honed in on an individual's tumor, are exquisitely sensitive and specific. But I always warn patients, they will never pick up a new breast cancer or a new colon cancer. It can only pick up your original tumor because it is so keyed in using that tumor informed approach. And most of the things they're tracking are not actually DNA that codes for proteins and druggable targets. Only about 5% of those 200 to 1,800 mutations are. So again, it's a very different use and a very different methodology than what I think a lot of people are used to, the ctDNA for metastatic patients looking for PIK3CA mutations, et cetera. This is purely for tracking microscopic disease.
Okay, so we have a couple more questions. At what point would ctDNA be checked post-operatively here to prognosticate days,
Yeah,
weeks, or 3 months?
this is on one of those gray zones. We don't know. So I'm following kind of our paradigm that we did in the study because that's the best data that I'm aware of, and doing it, if we can, pre-operative or pre-neoadjuvant therapy, post-neoadjuvant therapy, and then after surgery. But I've also done it on some patients who have gotten surgery up front and then following them. The key is, I think, tracking. What I really want to know is, because I don't feel comfortable withdrawing standard of care curative therapies with a negative result, knowing that there's still a small but real amount of false negatives. We should only be doing those types of studies in a clinical trial, is my philosophy. So I'm much more keyed in right now of finding the positives, those patients that for whatever reason did not respond to their adjuvant therapies, did not get everything cleared by surgery. Those are the opportunities where I feel like, as I showed you with my patient, we potentially could cure more. And so for me, knowing, looking at the data with these tumor informed assays, there's almost no false positives. So if someone has a positive ctDNA by this assay, to me, that means they are not cured. And I almost feel it's unethical not to try to do something. At least that's the way my brain thinks. So that's where between now and the future, I'm focusing on right now. And so we don't know the optimal time to be checked, but based upon things, usually most of us now who are doing this are thinking about every 3 to 6 months.
Okay, and then we have a question from Brenda. When you repeat ctDNA post-surgery or for monitoring, do you run the same test or specific to previous results? I'm curious how much this is costing patients.
So fortunately, we get Personalis through Tempus, and I think, as you know, Brenda, we follow that paradigm where most of the patients don't pay a penny out of pocket, like 80% of them. So, and we use the exact same. The first test takes a long time, about 4 to 6 weeks, sometimes even longer, because they have to take the tumor, they got to sequence it, they have to find the 200 to 1,800 mutations, then design probes, and then they'll look in the blood that was drawn at that same time or whatever time period that the test was ordered. The subsequent tests use those exact same markers, but remember, they're individualized for every patient. And so now that they've banked those, they can use those and get it done within a couple weeks. And so the first test takes the longest because you have to sequence the tumor. All the subsequent tests are cheaper, faster, because it's the hard part's already been done in terms of the tumor sequencing. But again, we're fortunate that, and again, Medicare has now been approved for this test, but we're fortunate that by working through Tempus, who kind of has become the Amazon marketplace of NGS testing, we follow the same paradigm for this.
Okay, and then final question, applications for I think I'm reading it, BRCA, other cancers. Any closing thoughts?
I think breast cancer application for other breast cancers, meaning like ER positive, HER2 negative, I'm assuming,
That's what I can't tell what the question
or
is.
other cancers. Yeah. So again, we've only done our study with HER2 positive, although there were any ER status in those. So about half of them were ER positive as well as HER2 positive, and then triple negative. The company has already published many other studies with ER positive, HER2 negative disease, and I've used it in those patients. It tends not to be as sensitive because that subtype of breast cancer tends not to shed as much cell-free DNA as we call it, or shedding as we call it. But it's still pretty darn good. And again, I've picked up some patients who have ER/PR positive HER2 negative disease as well. And again, there's a lot of studies using this assay that have shown that.
Okay, and then here, one other thing. Wait 1 second. You could hypothesize neoadjuvant may induce mutations, which would change probe post-op.
Yeah, no, it's a good point. Um, this is one of the reasons why. So other companies now, when they say they're at 1 part per million, they're only using 50 to 64 probes. And technically, that probably is enough. Part of the shtick of what Personalis has done and why I like this philosophy is that we're over calculating because of this exact reason. As cancers evolve and mutate, they could lose a marker or two. And so by having kind of a safety net of 200 to 1800, that is much, much less likely to occur. And again, our data and some others would speak to that.
And then this question, could individualized probes detect another cancer within a patient? Based on what you just said, I would think the answer
Highly
is
unlikely.
no.
Highly unlikely. Yeah, highly unlikely.
And
I won't
then,
say it's impossible, but it's kind of probably would be like winning the lottery, I think.
you know what, though, Ben? This is where I also think with the inherited cancers, because they develop potentially through the same pathway, there
Yeah.
could be potential there versus your sporadics, right? Because if there are specific mutations that are enriched for, which I don't know that we have a good handle on yet.
That's a great question. I don't know if anyone studied that too. We should probably think about studying
Yeah,
that.
no, that is something that I think is being studied by other, yeah.
Just
It's
whether
not
you
well
have
studied.
similar, yeah. But
Yeah.
even with that, for me, it would be hard to imagine. Let's say you have a BRCA1 patient or a carrier who gets a breast cancer, then gets another breast cancer. Part of the requirements for these, at least in mice, but we see this in humans too, they almost always have to have some sort of TP53 mutation, right? And so if it would be easy to look because the TP53 mutations, if they're the same, you would presume that they're either the same cancer, but or maybe your hypothesis is true. But if they're different every time, that probably tells you it's going to be very, very unlikely.
Yeah, and that's the thing. Like we have, Sonia and I have some of this data, but there's other genes. So really what we need to do is look to see, like we know what genes the mutations are in, but are there recurrent specific mutations, right? Like that's what you have to get to potentially to be able
And
to.
oncogenes like PIK3CA, right? You can see those multiple times, and that wouldn't be unusual. But that's also the thing. They don't call a mutation on a single, or they don't call positive on a single mutation. They have their own proprietary secret sauce algorithm, and not every mutation is weighted the same way because there are certain regions that are easier or more difficult to detect based upon repeats, et cetera, in the genome. So there's
And
a lot of
really
secret
then,
sauce.
yeah. And then the other thing is you'd want to have the early changes, not the late changes. Because
Correct.
like
Yeah.
if you're diagnosing it when it's already metastatic, what good are you doing? There's
Correct.
another question here. You mentioned patients coming to you requesting to be ctDNA tested. In your experience, how do patients learn about these platforms? How common is it for providers to recommend ctDNA testing?
I think they learn through platforms like this. And I mean, Facebook, social groups. That's what I have patients who tell me that they've learned about this through their online support groups. Certainly now there's probably more in the literature than there ever was on this type of things. And I don't think most oncologists are ordering this a lot of times because they're not sure exactly what it is, but also what to do with the results. And I think that that's where it's really challenging right now. And I tell people this all the time. The Ben Parker 20 years ago would never order these tests until we get the clinical utility studies done. That will take another 10 years. But I'm also 58 now, and in 10 years, I'll be 68. And by the time we get those data, I'm not going to have, I don't know how many more productive years of being an oncologist. So I feel like there's a lot of patients I can help between now and 10 years from now, like the examples that I pointed out. So I've evolved my thinking of being a data-driven snob, which is what we usually are in academics. And I think in this particular case, because I'm comfortable, help develop a lot of this, the platforms in the background, that I feel it's okay. But I think we also need to help patients and providers understand this. So I was very proud because one of my former medical students at Hopkins, she's now at MGH, Dr. Ariel Medford, she reached out to me. And this is like so funny because Tua knows I do a lot of these virtual molecular tumor boards. And she reached out to a bunch of said, you know what? I'm thinking we should have a virtual molecular tumor board just on ctDNA MRD. And we're getting ready to form that. So I felt like that was a great thought on her part. And I don't know, I felt like a proud dad.
That is fascinating. Okay, so we will go on to our cases where Ben, these were designed for your expertise.
Awesome.
I'll let Mariah take it away.
Okay. Thank you, Dr. Ben. That was a really helpful presentation. My first case isn't 100% on theme, but thought we would get your insight on it. So this patient is a 28-year-old female. She was diagnosed with stage 1A juvenile granulosa ovarian tumor at age 26 and had her left ovary removed. She also had a colonoscopy due to GI issues that she was having, and she was found to have multiple ganglioneuromatous polyps. You can see in the family history, not much. She had some relatives with melanoma and a grandmother with lung cancer. So she initially had genetic testing in October 2023 ordered by her gyn-onc provider, and it was Invitae 84 gene panel. So a really broad panel, and results came back negative. She then had Tempus XT that was completed on the ganglioneuromatous colon polyp tissue that was completed in November 2024 and was also negative. So she came to me for genetic counseling and discussion of additional testing in September 2025, so just a couple months ago. And so I ordered Cancer Next Expanded with RNA. Her initial testing through Invitae did not have RNA, and so that had 77 genes.
Mariah, do you want to say what the working diagnosis was? You may have said it, I just missed it.
Because of her history of ganglioneuromatous polyps, she was actually seeing a provider here at Vanderbilt for NF1. They had suspected that she had neurofibromatosis type 1. We repeated the testing with RNA and we found this mutation, likely pathogenic mutation in P10. So you can see based on the CDOT that it's a deep intronic variant. And so I included some of the information that was provided on the Ambry report, but I also reached out to Ambry and they said, we have seen this in a few other patients who have classic features of P10 hamartomas tumor syndrome. So this is likely the answer for at least the polyps. Upon additional history taking, now that we had this diagnosis, she was identified by Tua to have a large head. She had a history of a lipoma, a large lipoma removed in childhood that didn't come up during our genetic counseling appointment. And then upon further physical inspection, she had facial findings suggestive of trichomonas, although they weren't biopsied, as well as oral findings suggestive of papillomas, no acral or palmoplantar keratoses noted. So then we did undergo testing for her son, who has a large head. So we were concerned that he was going to be positive, but he was actually negative. So that was reassuring. And testing for her mother is underway. And her mother was also identified to have a large head size. She came with her daughter to the appointment. So that was measured as well. So thinking back to the family history, there are not suggestive features of Cowden syndrome. So we're wondering, is this a de novo case? So I'm going to go back to the family tree. So, again, her mother is being tested, and I guess based on the findings of that, can coordinate testing for her father, but really nothing suggestive of P10 in that history. So this was a very interesting finding for us. So came with a few discussion points here. So the first was the P10 mutation was not identified on the Tempus XT test. So that's just something to think about, that the XT test is not a validated, hereditary germline test. And then after
Can I
talking
ask
with
a
Ambry,
question though,
oh, sure.
Mariah? Now that Ambry has taken over the Tempus, well, no, it wouldn't be Tempus XT. Would Tempus XG catch it?
Yes,
I don't know what
because
If you
any
put
of that.
RNA,
Yeah,
yeah, if you
XG
put
is
RNA
just Cancer Next or Cancer Next expanded.
With
Yeah.
RNA.
with RNA.
Yes, with you, yes,
Okay.
with RNA. But my next point here is that Ambry has added this mutation to their what they call their DNA exception list. So they have built out coverage at this position now and report this variant in individuals, even
Oh,
if they have DNA only panels. And so that was why for her son we could do saliva. We did not need to do blood for RNA analysis. And so now, theoretically, if there are other people who have this variant and are just getting a DNA only panel, it should be identified. So that was really reassuring to hear. And then just thinking about, is there a connection with this germline P10 mutation and the granulosa cell tumor? So it's just odd to think about the fact that she has this mutation, but developed this tumor sporadically. So that's just a question that we have. Is there any sort of connection? And I think we'll just have to wait and see as time goes on. And then she is possibly interested in PGT. So, there are some potential struggles with that, ensuring that the PGT lab would be able to detect this variant, given it's such a deep intronic variant. So Dr. Powell made sure to really go over that with her, to have a detailed discussion with the lab that's doing the PGT to make sure that they would be able to detect this variant.
And along those lines, we have a question in the chat. Just curious, did you ask Invitae if they'd be able to see this?
I
I
didn't, but I should let them know about this. In ClinVar, Invitae does not have an entry, and I know that they are really good about contributing their classifications of variants. So I do have to reach out to them.
my suspicion is if they had ordered RNA, they probably would have found it. It's just that this is such a deep intronic mutation that it's not going to be picked up. And that's also why it's not picked up on the Tempus XT. This is still a gene panel test. I can't remember if they've switched over to whole exome and then they bioinformatically do the panel, or do just the hybrid capture of the 500 to 600 genes that they're doing. But either way, they're not going to pick up the deep intronic mutation. So you would never find this on a cancer test in the current iteration. And I actually think a great question is what you just asked, Mariah, about the granulosa cell tumor. So since the tumor was already sequenced, did they do the XR component on that as well?
The XR component. I
The
would have to check.
RNA.
Yeah, yeah, yeah. I would have to check back on that, but my initial thought is that no, because I sifted through everything related to Tempest for her after we found this result to check
Mm-hmm.
that exact thing. So I do not think that there was anything out of the ordinary identified at all.
Because if there's the RNA expression shows low or underexpressed P10, that might be a smoking gun. And, I don't know whether or not you could ask them whether, if blood was sent, they can sometimes do LOH analysis for an allele. But they usually only do it if they find, something that makes them look for that. So it's worth thinking about. The other thing you could ask is, this is not the greatest, but there are some labs that can do some P10 IHC. And if you sent them the specimen to see whether or not they feel like there's in fact loss of P10.
But
In
Ben, is it going to change care at this point? Because it would have to be done on a clinical basis, right?
Yeah,
So,
this is purely academic.
yeah.
Purely academic.
So
Yeah.
will insurance pay?
Oh,
I'm
probably not.
yes, exactly.
Although again, our colleagues at Tempus probably would just do it since they've already got the tissue, and it may just be if they did the RNA, they could just flip a switch and start looking at it.
That's a good idea. with
Yeah,
them?
I can reach out to them. I know there's some questions. Gene Reviews does mention a possible association with melanoma with someone having an onset at age 3. Okay, that's interesting to know. I think she actually had melanoma on both sides of the family, so that doesn't necessarily narrow it down just yet. So still waiting on mom's results. If phenotype does not match, it is almost clinically irrelevant finding, low penetrance. Right, more of a comment than a question. The evidence used to classify that PTEN variant seemed very limited. I continue to be cautious when trying to interpret those deep intronic variants without sufficient evidence of pathogenicity. Also, I wonder what Invitae would have classified the variant as if they had detected it with RNA. That's a good question.
Yeah.
I think I will reach out to Invitae just to, out of curiosity, to see if they have identified it and what they do classify it as. But that was one of my initial thought processes too, was it was classified as likely pathogenic, but after hearing from Ambry, one of Ambry's reps, that they have seen other individuals with this variant who have, classical symptoms, that made me feel a little bit better about it. But you're definitely right
She
that,
meets the diagnostic criteria, which we wouldn't have known because we weren't suspecting Cowden
Mhm.
when she was first seen by Mariah, but like she's got the skin finding, so she's got Cowden's. Um, the other thing is, and I think
Fascinating.
we discussed it in our clinic case conference earlier this week, because as Mariah said, Ambry has added this deep intronic variant to their DNA panel, so they would
Yeah.
detect it just on DNA, which is
Yep.
why that's what was sent for the son. But all labs, like there's variation in which labs do it because labs are curating this information from other labs to add to their panel. So Brian was saying it's just variable. So you just need to check with the labs to see if this has been added or not.
And presumably they'll put it in their fine print about, because most of the times they'll say if they don't do the whole coding sequence, right, they'll list it, etc. So presumably they would now put this in their DNA testing.
They would, but but this would be intronic, so it's not coding, right? So
That's what
I
I
don't
mean. So
know.
they would put, because there's even
Oh,
some
they
gene,
would put a,
right?
yeah.
Yeah, they put it in the bottom that this will also detect,
Yeah, yeah, yeah. You're right.
intronic
So we would
sequence,
be
blah,
able
blah,
to
blah,
see.
blah. But who reads that, right?
Exactly.
I think it's fascinating. I order RNA on everyone for point of care testing if I'm gonna do point of care testing because I figured, it's uncommon, but this is a perfect reason why. And Tua, how many do you think we've actually found by RNA only at this point?
I mean, Katie could comment, but I mean, it's been a handful. Definitely been a
Yeah,
handful.
I think maybe five at least.
I remember three a couple years ago for sure.
Mm-hmm.
So yeah, it's very uncommon or maybe rare, but at the same time, if you're that patient and family, it could have huge
Exactly.
Happens. Yeah.
implications.
No, we've definitely seen it. Okay, Mariah, go on to your next case because this
Okay.
one we really want Ben's take on.
Yes. Okay, so this one's a little bit more aligned. So the patient's personal history isn't super important, but she was coming to me based on a personal history of sebaceoma and 5 paternal relatives with unknown types of cancer. So her provider had a small suspicion of Muir-Torre syndrome given her finding and then, having these multiple family members with cancer. So to her genetic counseling appointment, she brought several documents that she thought would be important to share, including the Gallery multi-cancer early detection test. So her and her husband both paid about $1,000 out of pocket for this testing. It was not covered by insurance. So she had that testing completed in August of 2024, and the results came back normal. So, we were just wanting to know your thoughts, Dr. Ben, on the use of the Gallery multi-cancer early detection test as a screening tool in the general population. I forget who ordered this testing for her, but it was most likely a primary care provider. And then also your thoughts on the reported performance statistics, specifically the positive predictive value, which is reporting out now is 43.1%. This is a screenshot from the test report, by the way. And then just wanting to hear your thoughts on how should clinicians interpret these metrics and how should we be counseling patients regarding the potential benefits and limitations of this test and unaffected individuals, I should say.
Yeah, this is an area where I think this is not ready for prime time. And, Gallery had their first study, which was pretty not great data. They've recently published like a second study that was better, and they're trying to get FDA approval now based upon that study. But I think it's kind of like boiling the ocean. And I think the approach that seems to be more effective is what Gardner did with colon cancer that was published in the New England Journal about a year or two ago, where you use it as an adjunct. It's almost like a blood-based version of Cologuard. It is not a replacement for colonoscopy, but it may actually, and I think Cologuard has some data to speak to this, it may actually get more people to get real screening if it comes up positive. There are false positives, there are false negatives. That's kind of the nature of what I call the tumor uninformed assays, which are also going into the MRD space, as I mentioned earlier. But this is still, I think, several log orders behind than the stuff that I was talking about for MRD. It's a hard field right now. The other really tough part about prevention, and again, who knows whether thinking will change on this, but if you're a purist, any intervention really needs to show some sort of benefit of disease-specific survival or the gold standard of overall survival. And this is why I think screening modalities and diagnostic tools have been so difficult in the primary prevention space, because it takes a long time and a lot of people that you need to screen to actually show, for example, mammography does actually save lives from breast cancer. PSA has still been somewhat controversial. And that's why you see different governing bodies and organizations have different opinions and views about it, whether it actually saves lives from prostate cancer. I'm sure it does for the times it picks up very aggressive prostate cancers, but there are a ton of men, probably myself included, that have prostate cancer that's very indolent and won't die from the disease, but from with it. That's the hard part with these types of primary prevention screenings, to really show that benefit across all cancers, I think is really challenging. And I think it's probably makes more sense, and I'm working with companies on this now. Let's develop a better adjunct or adjunctive or, adjuvant diagnostic modality for mammograms. That could be a blood test, right? So if someone has a BI-RADS, whatever, this could further refine the likelihood that this is in fact cancer or not. To me, I think that's where the baby steps are going to yield more impact in the short term.
Okay, so there's a lot of stuff going on in the chat. One thing from just our comments from the prior case, the details of the specific intronic variants is not often in the fine print per Brian Schertz. So I guess that idea is not going to potentially work. And then other questions, how often should Gallery be offered? Recently heard Gallery trying to say PPV about 60% now with Pathfinder 2 study.
Yeah, that was the second study that I mentioned.
Yeah, near
It's
PPV.
better, but is it good enough? I don't know. I personally don't think so, but that's just my opinion.
Okay, and then you have other questions here. How often? Do you have a comment? I mean, we're saying we're not sure it's ready for prime time, so giving the comment about how often is probably a tough one, right?
It is, but if we could get a really good assay, why wouldn't we do it yearly? But that's the problem right now. I don't think we have those really good assays. Gallery is also using a methylation technology that, and again, they may have evolved this, but the original testing was a pretty old school type of test that really hurts DNA by sulfite treatment and sequencing for methylation. Most kind of companies that are doing this nowadays in the cell-free DNA space are using methodologies where you use immunoprecipitation to pull down methylated DNA, and that way you can actually do the whole methylome, so to speak. And I do have hope that those newer technologies will yield better results and better tests, so that someday, yeah, we may get a blood test that will be really good in terms of its NPV, PPV. I just don't think we're there yet, and I'm not sure this is the right technology.
Okay, Ben, some more questions for you.
Sure.
In general, which assays are better to detect tumors? Methylation-based or mutation-based or combined? And then there's another question I want you to get to is, interested to hear whether you think GCs should be involved in counseling ordering Grail, Gallery, or other blood-based multi-cancer early detection tests.
Yeah, great questions. I think that the best way for detecting tumors has yet to be shown. Right now, I'm convinced, and admittedly I'm biased, that looking for lots of mutations not only increases or gives you the best sensitivity, again, just for that individual tumor, but also the more mutations, the more likelihood that you will continue with that sensitivity as the cancers evolve and grow. Again, that's kind of why I like the philosophy of using 200 to 1800 mutations. But I also think there's great hope to use combinations of mutations, methylations with the pull down IP methods that could yield a much higher sensitivity and maybe even specificity. Although again, specificity is pretty darn good right now. I would love if genetic counselors would be willing and able to also help with these types of MCED tests, because I do think that you're going to run into issues where you're going to have families that are going to have a lot of cancer. Of course, it's almost a self-selected population. They want to know, do I have cancer right now because mom had it, my maternal aunt had it, my maternal grandmother had it. And so I do think that that day is probably coming. Probably not there yet, but certainly would be. And I would even further that, because I would love to have help counseling patients on these ctDNA MRD tests. Those last 3 slides that I showed you where I go into all that, that's like genetic counseling to me. It takes a long time, and you have to really educate patients and their families about what these tests can and cannot do.
Okay, here another comment, which I mean, I agree with. Regardless of whether we trust gallery testing for prime time, it is here and patients are asking for it. I believe that GCs do have a role in counseling about limitations and nuances of ctDNA screening in blood. This is controversial in GC world. I do believe it's in scope of practice and works well with the traditional cancer GC visits, which I'm just going to comment. I agree with it, but I think that this requires, like, it depends on your comfort level. And I do think training would be important. And I would say the same thing about me. Like, I've had to learn a lot of things that I wasn't taught in fellowship that have evolved over the last few decades. So I agree. I think the principles of genetic counseling apply to this field. It's just the nuances would need to be learned, like through training programs or through, attendances at what Ben's type of case conferences and that kind of stuff. The other thing I was just going to comment on is with these ctDNA tests for screening, you can also sometimes pull out, like, find people with germline, right? Like, it can work the other way where, like, seeing as this is an inherited cancer focused
Yeah. No, it's again, those are the types of tests that we've been using for a while in metastatic patients largely, although we are moving. So they're qualitative in nature, looking for mutations, but both, Tua, Katie, Mira, everyone here who works at Vanderbilt, we've seen using these liquid biopsies, mutations in germline genes that have a VAF of 50-some% or greater. And that also requires education. I'm actually presenting at San Antonio on the molecular tumor board a case where someone had a garden test, and I think, Katie, you saw this this family for me from a Northeast institution where they were sitting on this for months, and it was everything had these low-level ESR1 mutations, but here's this BRCA2 mutation sitting and screaming at 70-some%, and it was germline, and then both her sisters tested positive, and the patient has metastatic breast cancer, now can get a PARP inhibitor. Both the sisters tested positive, are getting counseled and screened. One of their daughters is tested positive. So, we can actually find a lot using liquid biopsies in the somatic space, so to speak, looking for druggable targets.
Yeah, so I apologize. We're a few minutes over, but there are some other questions, Ben, that I think the group would really benefit from your input, or they would welcome your input. So, what is an acceptable PPV for a screen when you consider that this is meant as a screen and not a diagnostic test? Does that change anyone's opinion? My biggest issue is the lack of early detection.
Yeah, I think it's a great question. A lot of stuff like Cologuard and garden tests, people are for sensitivity, specificity, in the 80-some percentile. So you're missing it. And the biggest fear that I and many people have is that people will take that negative and say, you know what, I don't need to do my screening colonoscopy because I'm negative by this test that is not a replacement. And then similarly, when you think about the false positives, because there are going to be those as well, that drives a lot of angst in people when they see that, as you can well imagine. So I don't know the answer to that. I don't think anyone does really. Brian had um, his view on population screening. And I do think that a good place to start is for patients who are at higher risk so that we have adjunct tests to really help us manage these patients.
Okay, and then how soon do you think the lines will blur between multi-cancer early detection to ctDNA for therapy decisions to MRD all in same test?
I think that day will probably come in the next 5 to 10 years as technologies continue to improve and sequencing costs keep getting down. But again, remember the ctDNA MRD tests, most of those variants that they find, somatic variants, and they always actually use a Buffy coat to make sure they're somatic, are not going to be in coding region. So companies right now are doing these 2-for-1 tests when they do, for example, the diagnostic biopsy. Not only will they find those, they'll also do in parallel looking for the 500 genes on their gene panel as well. And other companies are coming out with ways to do that in the blood. Caris is an example where they have a whole exome blood test. It's not that sensitive in its current iteration, but the way they fill in the gaps of the exome is they use RNA. So there is circulating cell-free RNA. And that kind of makes sense, right? Because you take the RNA, that the transcriptome is really the exome with few exceptions. And so that's how they're filling in the gaps with using RNA.
Okay, and then I'm just going to read what Katie wrote as our last word, so which I agree with. And again, just to give context, Katie, we were able to recruit Katie from a community-based center about 5 years ago. So she leads our hereditary cancer clinic. She's a director of genetic counseling services. So Katie has worked both in the community and the academic setting, so has specific, what's the right word for it? Perspective on this. So here's what she says. I think it also depends on the system you work. If you have a predetermined pipeline of knowledgeable providers to involve based on results, it can work. If you are one of many GCs on a bit of an island, I would worry about what comes next. Where we already see it with germline VUSs, for example, when patients are overtreated out in the community. Katie, I don't know if you want to add to that, but
Here, here.
completely agree with you.
Yeah, like I think it's not necessarily just our skills, it's about the big picture of, yeah, we might do a great job, but that's the one moment in time and what happens to that patient next and in the hands of the next provider. And that's where I worry about these new things.
Yeah, and thankfully we have a direct line to Dr. Ben. So we get any of these tests, we just email Ben. But again, that's where I would proceed with caution. If you are on a bit of an island, just have a plan in place if you're doing this kind of work in terms of, well, where are you going to go with it? Because, I think all of us are struggling with it, including Ben, sometimes with what to make of this. So,
Yep. But if anyone on this call ever has a question, I'm more than willing to help and answer. People here at BICC know that I try to answer all my emails within 24 to 48 hours. So just shoot me an email. I'm happy to help out if I can.
so can we put your email in the chat?
Yeah, absolutely.
Okay. So we will do that.
Now, if I get inundated with thousands of emails, it may take me more than 1 or 2 days to respond to you, but I'll just leave you with that caveat.
Okay, well, thank you, Ben. That was tremendously enlightening to all of us. We're excited about our upcoming case conferences in January. We have Heather Chang presenting on inherited prostate cancers. And then in February, we have Elena Stoffel from Michigan presenting on gastric cancer and CDH1 carriers, which again is a very hot topic that, again, many of us are struggling with. So, with that, I thank you for your attention. I thank our presenters. I thank our guest expert, and we will see you next time. Thank you.
Thanks, everyone. Happy holidays.
Bye.